Good afternoon. I want to thank you for the opportunity to talk today. Here are my disclosures. The original plan was for me to talk about our program here in New York City at Center for Special Studies, where geriatricians are embedded in the HIV practice. But everything sort of fell apart this winter, and we still have not come back to normal, nor are we sure what normal is going to be. And I wanted to take the opportunity to talk about other things that have been happening both before coronavirus came and also even as we are reconfiguring our practices. And that is government partnerships in improving care with HIV. There are some silver linings to the COVID epidemic. Some of them have involved use of telemedicine. Some have involved the recognition of social isolation among consumers. But as well, it is this opportunity to think about how we're practicing and how we're caring for our patients. And are there opportunities as practices are disrupted to change the way we do things? I want to begin by looking more carefully at New York State. This is a map that depicts the prevalence of people living with HIV 55 and older in the United States. New York State is the darkest state here. That is, it has the highest prevalence, and nearly 1% of people 55 and older in New York State have HIV. If we look more closely at the map of New York State, this is county by county, and this represents all people with HIV. HIV is common throughout the state, not just in New York City, but in smaller cities like Syracuse and in rural regions. The table describes the percentage of people with HIV who are either 50 plus or 60 plus in New York State. This is New York State total. This is non-New York City. So the 50 plus population is well over 50% throughout the state. More to the point, those people who live outside of New York City are slightly older. So people are aging with HIV throughout the state in counties that are rural, urban, of every type. And one of our challenges is to help all of them. Now, most of us are up here, and we collaborate to lesser or greater degrees with local, regional, and federal entities. And I've described these silos here for New York. New York City Disease Control is this Department of Health and Mental Hygiene. At the federal level, I want to concentrate on the programs that fund care, in particular HRSA. HRSA's Ryan White program provides care for more than 500,000 people with HIV, and roughly half the people in this country who have HIV. Many are familiar with the education training centers, but I also want to mention the geriatric workforce enhancement programs that HRSA also funds. So we have this interesting opportunity where HRSA funds both HIV care as well as geriatric training. And one of the challenges is to figure out how to combine those things that HRSA is supporting. In New York State, the AIDS Institute has a number of committees and programs, and they've offered me opportunities to learn and work with others. So I wanted to talk a little bit about what was happening before and after COVID-19 struck. In early 2019, I joined the Medical Care Criterion Committee and had an opportunity to present to consumers in September one of the consumers at that meeting, John Wicara, said, come on up to Syracuse. And we hurriedly put together a workshop for local providers and consumers in Syracuse that the AIDS Institute supported. A few months later, I spoke in Albany and also met with providers, local providers, to try to help them brainstorm about how they can improve care with HIV. We have since established a joint subcommittee with consumers and providers on HIV and aging and long-term survivors. And I want to emphasize that a lot of this programming is consumer-directed and consumer-driven, and is a collaboration between providers like myself and consumers, and is statewide. And the AIDS Institute has been funding Zoom programming for support groups, but also has been funding personnel and town halls and surveys that this subcommittee is directing. Many of you have participated in the recent Ryan White meeting and are familiar with Ryan White aging initiatives. Some of the earlier ones are the National HIV Curriculum and their HIV and Aging newsletter, but more recently they have had a number of webinars, and what is in progress, and I think is especially exciting, is what I mentioned earlier, which is the partnership between the geriatric workforce enhancement programs and the Ryan White programs. In addition, they're producing some reference guides on screening and assessment, and on leveraging the resources that one has locally. New York City is taking a slightly different tack, in that not only are they doing trainings and preparing resource guides, but on the basis of recommendations, they have an RFP out to build a program that their RFP says directly it should be modeled on Golden Compass. They are very interested in having a large-scale program to enhance the care of people aging with HIV in New York City, and their focus is on achieving equity. So they are looking both in terms of local training as well as developing programs that have been described and modeled here today. So it has been a very unusual year for me in that I've seen much more interest in aging with HIV and trying to improve care of people aging with HIV at all levels. And I don't think this is just a tide coming in, and I really think this is a sea change, and I would love to hear from others in the group about what they are seeing locally and regionally in terms of support for these programs. I truly think that the quantity and support of educational content and technical assistance has changed. I do think that there is a sincere commitment to improving care, and the funding is a bit more plentiful than it has been, even in the setting of COVID-19. The roadblocks that I've seen include the difficulties in meeting the needs of clinical sites of all sizes and all regions. There is as well, at least as consumers have told me, somewhat of a competition with the ending the epidemic message. Some of the funding for these programs and webinars are through ending the epidemic programs, and I think sometimes consumers feel that their aging issues are lost in that message, and I think we have to make sure that their needs are being heard and met. There are also still too many silos. We have had many town halls. We have had many webinars. How do we get the best value from them? What is the added value of an additional town hall that we can get based on other information that's been gained from other meetings? And how do we facilitate linkages? If we sort of think business-wise in terms of the organizational behavioral world, we're here. Those academic programs that have received grants either through foundations or through government programs are transformative. We have the money to hire new people, to create new programs, and serve as models. And I think that's what has been so exciting about what we've heard today. But most local programs are here. They're incremental. And I think that one of the lessons I've learned over the past year is how they're going to reconfigure their programs with such limited resources, how they're going to meet the needs of their older patients when they are strapped to begin with. And I think some of our biggest challenges are taking what we're learning now and figuring out how local programs with far fewer resources are going to take what we've learned and use them. So the bottom line message is that there's a great deal more educational opportunities. There, I think, is a great deal more support for communities to improve care with people with for people with HIV. And I've put on this slide some of the local, regional, and HRSA-sponsored resources. And I hope that in future meetings we'll have opportunities to think together about how we take what we're doing and we're learning and help local programs.